Topic today is mobile applications and medical end-user devices. And I think we're going to cover a pretty wide range of topics here and encourage you to participate, ask questions. I might encourage you to move a little closer to the front here. Might be a little easier to, so if anybody wants to move up, now would be a good time. So, but let me introduce myself. I run the engineering organization for IronKey, and IronKey makes the world's most secure flash drive. We've been in business for over 10 years. It's extremely secure product used all over the world for encrypting, hardware encrypting data, used in a lot of applications, government, a lot of healthcare applications. The other interesting thing about it is completely indestructible. So for I'll fire that up. It currently has my Windows to Go work operating system on that flash drive, and I'll fire it up after the session today. But let me introduce our panelists. First, Edmundo Robinson. If you could give us a little bit of background and bio, that'd be helpful.
Sure. So I am. I could probably not use the mic. I work for Christiana Care. Christiana Care, and I'll tell you what I do. So Christiana Care is one of the larger health systems in the Mid-Atlantic, and we have a couple of hospitals and take care of quite a few patients. Largest system in Delaware. I serve as the senior vice president for Christiana Care, with some specific duties around. I'm the executive director of our Wilmington, Delaware campus, as well as associate chief medical officer for the health system as a whole. If you notice, none of those titles have information or technology in them. So that's not what I'm bringing to the table in this discussion. It's much more a small bit of end-user experience, as I'm a general internist, but more kind of a senior leadership outside of the IT space perspective on thinking about mobile and end-user activity in this space. And so it's something that we think about, certainly I do in some of the things that I'm working on quite a bit. And so I have some perspectives and some questions, maybe not as many answers on in that space.
Great, thank you. Our other panelist is Cal Bugara from Northeastern. Cal.
My name is Cal Bugara. I run an information systems program as part of the College of Engineering there. I have about 500 graduate students in the program in information systems, heavy software development group. So a few years back, I got involved in a couple of challenges from a couple of medical units in the Boston area. And with my interest in how to build more complex software more efficiently, I found these challenges to be quite interesting, and as a result, I went through quite a bit of an experience dealing with the issue of how to build mobile applications. Hopefully, I'll share some of those thoughts with you today.
Okay, well, let's kick this off with just a couple of thoughts on the mobile application piece of this challenge. I think we're all aware these days that mobile apps are popping up pretty much everywhere, and people are expecting to get access to information and control their lives through mobile apps. I think we can see the need for information sharing both within the healthcare organization, so kind of peer-to-peer sharing, and then as well with the patient and caregiver interaction. I think there's opportunities there, and I thought it might be good just to talk a little bit about where we see the biggest need, where we think the bar is today, and where it's going to go in the medium term, short to medium term.
Certainly, from my perspective, excuse me, the bar is quite low, so lots of opportunity there. And so just talking about kind of provider to provider, right? So there's a few things that we really need to be able to do securely, quickly, consistently. So one is from a mobile perspective. So one is communicate with each other, right? But communicate with each other around a patient specifically. in that patient's care. That's what providers are actually spending a lot of their time on. We're not chatting about going to our next golf tournament, although we might, but really the communication that needs to be secure, of course, needs to be around the care of a patient. So how do you actually pull and link all of those pieces together in a seamless way? The other communication from a provider perspective is actually accessing the patient's data from a mobile platform, right? So I have physicians who are on call. And they may not be at their computer at 2 o'clock in the morning, right? They may not be at their computer at 6 o'clock. They may be at dinner, but they're on call. And so, how do I? But they really need to have that access to that data. So what does that solution look like? And they may be very different. So that's actually those. Again, I think the bar is set pretty low. We're just not there in a way that I'm confident as a senior leader. I have confidence that we're actually there. I certainly haven't been able to sign off on anything that says yes, that's where we should be going. So that's one whole sticky wicket right there, and then you've got, as you mentioned, the patient experience, and that's where I'm spending a lot of my time on, because quite frankly, the competition around optimizing the patient's experience in their health. And not just health care, I separate the two, in their health. Because most patients are more interested in their health than they are in the care that I provide as a provider. They're much more interested in their health. So really being more kind of broad in your thinking about it. But there's a lot of competition in optimizing that experience. And as a healthcare provider, I need to be in that space. I need to be playing in that. But I've got to do it a different way. I might have other constraints that some of these other competitors don't have. But I still got to compete in that level. So I really need to have an optimal experience that allows me to be a player and not have the experience that the patient has be dictated by someone else. I need to be the one as a provider to dictate the patient's experience so that they are sticky with me because they identify with the brand that I'm presenting.
Good, Cal. Any thoughts from your perspective on the mobile app world? How it applies to your world?
So to me, mobile application is a little bit more different than having an app on, or at least this is the experience we developed when we started working on these two projects. I'll share with you just our findings. One application, this stuff has been going on for about last 4 years. One application is that we have high-risk roaming patients in the Boston area. They tend to be homeless, having all kinds of problems. And there are a bunch of good-hearted nurses going around in a van, chasing them around. But they don't know, there's no record of them. So we got engaged in building an app for this mobile van that will keep track of these patients. The model there, we just jumped into the application just because it looked interesting. But the reality is that the model is that the patient is roaming, is mobile, the van is mobile, and suddenly I realized that the software is the stabilizing thing in the whole thing. Because from anywhere, these guys, so the van will be going to Springfield, Mass. There would be a bunch of patients there. They come to Boston, a bunch of people come to see them. And these patients pop up everywhere. So an electronic healthcare record system in the air was just a very stabilizing and bringing a lot of information to these nurses taking care of these patients. So that was the learning experience. That mobility here is a true mobility. The business, it's people who are mobile trying to, and these nurses just doing an amazing job. This is about HIV and all kinds of diseases, and trying to control the spread of this disease. So, building an architecture for that kind of system took quite a bit of, know-how, and of course with zero money, that made it even. There's no budget, there's nobody on our back to deliver this quickly. So we ended up doing a quality job on this system. But of course, now try to push it to get somebody to pay money for it to support them became a completely different exercise. we went through the state and said, look, we're helping these nurses. It turned out actually the only people who are funding that group was the CDC. And the CDC were paying for this van so these guys can go around and collect, how many patients have HIV. They were not interested in reducing the spread of disease. And they said, we're not interested in funding this project. All we care about is just gathering data. So who has it looks obvious to you from a business model perspective that, these people are infecting other people, but there's nobody in charge of, having that impact. That was quite a surprise for us. So, but the other one that's a little bit closer to my heart is the partnership with Boston Children's Hospital to build a mobile app for their transport team when they transfer children from one hospital back to Boston Children. So there's a lot of communication. Again, the transport team, all they wanted is a way. It was the transport team. They needed an entry system so they can do a report at the end of the day. When we finished with that application, again, mobility of the patient, mobility of the nurses, and ended up a true system between two hospitals. So it became a real-time sharing of information. We realized that a lot of the intervention that happened on the road we ended up recording all the intervention that happened on the road that became available at the intensive care unit. So suddenly, this mobile application ended up about safety and reducing the medical errors at the intensive care unit. These are little babies, a drop of medication, a little bit more than necessary, and you've got a dead baby. And of course, miscommunication. Did you give the medication there or maybe not? So the tablet became a way to bring the referring physician and the medical control together in one single communication system. Everybody sees exactly the same data. So suddenly a real-time database where people can collaborate and multiple people are working together. And this is all came by that idea of a tablet that they can take with them on the road. But we needed to have the right infrastructure to create this virtual environment. So again, so this is a successful deployment at Boston Children's Hospital. And of course, how did we learn about all this real-time stuff? From the physicians and nurses that we talked to everywhere. One nurse out of the San Francisco Children's Hospital said, Cal, when I go home, there might be some interesting cases. Can I log into the system and see the case developing real time? I want to learn from these episodes. So things of that nature were coming up. Can we collaborate together to see the referring physicians want to be involved in what happened? Because traditionally, you let the child go and you don't know what happened. So with this kind of a real-time system, now the referring physician can see exactly what happened, what they've done for that baby. So people here in New York at the North Shore Hospital, this is becoming like a marketing tool. Because now it becomes a tool to bring the referring physicians in a relationship network. That there's more value in using our services than somewhere else. These became byproducts of just a simple application. Yeah. So there's more to mobility than just a piece of technology here. It's our social life and the way we are that's at stake here.
Yeah, I like the idea of a pretty specific use case you're going after, but has broader implications in terms of peer-to-peer sharing of information, whether it is happening in a mobile van or an ambulance, or whether it's just happening, with an on-call physician versus, somebody on the floor. Actually, sounds like good value in a number of those situations.
So they had us put it on an iPhone as well, so that became like the medical control can be on vacation somewhere. But their recommendation, it doesn't really matter when they are in the intensive care unit. They're still entering their recommendation what to do. But he or she could be anywhere for that matter. So being able to bring top-level expertise to the point of emergency care is a real possibility now.
Yeah, so expanding on that use case, right? So what's the market of emergency management services nationwide, right? So EMS systems all over the country, which are the trauma system's pretty well structured. I think that's one thing that we nationally have actually gotten pretty good is the trauma system, but they don't have this aspect of kind of mobile care. They do a good job with what they have, but they come in, they give me run sheets that are paper in the emergency department. I mean, like no one else in the hospital is using paper except for when EMS comes in and drops a run sheet in front of me. I don't even know what to do with that, right? So what if you actually expanded that concept to all EMS and actually had the physicians in the emergency department helping to manage the patient, not just kind of through the telephone, which is what they kind of do now, but really kind of real time patient care, including some of the kind of the vitals and all the other stuff, and really kind of have that EMS link in so that when I take care of the patient, when they get to the hospital, I know what happened to the patient, not just when they hit the ED, but I know what happened to them from the moment they were accessed by EMS out in their home or wherever they happen to have found them. Which, of course, now you can go even further if you go down to the one of the questions that you would actually raise, which is, what should patient information look like, and how do you access that? Which is a whole other ball of wax, because. But at least at the EMS system where you've got providers, really the extension of the care should really start from the moment that provider accesses that emergency, whatever that might be. So it's really just an extension of your use case, quite frankly.
So of course that will be the adult urgent care domain, right? But one interesting case out of Colorado, one of those Denver hospitals have airplanes as well. So the case will be that the airplane will leave from one airport, go to another airport. There's an emergency vehicle transporting a patient from a hospital to the airport. Mm-hmm. Now there's another nursing team that gets involved, and now the patient needs to be airflown to another hospital, another city. God knows the different levels of intervention that could have happened on the way before they get to their final destination, and potential for mistakes and miscommunication, right? Yeah. And now the fact data is consistent in one place, even though there are multiple teams engaged, is just a way to provide an accurate record of what happened, right? So this is not a record of what happened, is that did you give that medication or not?
This is really a coordination of care issue, not a mobile devices. I think you can plug into that, but we don't have the coordination of care infrastructure yet, which I think is what we really need. Mm-hmm. And then these other devices can plug into that. I think the problem is we're having a hard time getting people to understand the critical aspect of this coordination of care, mm-hmm. and to get serious about building an infrastructure that we can plug into.
I agree. Like IT is not going to fix bad process. So I completely agree that there's a process that needs to be fixed. But what I was making an argument for is that there's some areas where we have pretty decent process, and if we could layer good solutions on top of that, we have even better process.
I think IT is. I think I understand what you're saying, but I think there is a lack also at the IT level where we haven't managed to get the people at the business level, the policy level, to see that we need to, because I don't think we convince ourselves that we need to build a uniform layer that that you can use, that you can jump up and down on. Because I think, and if you think about the number of devices, it's not I don't even know what we mean by mobile devices in a year. I think it's really unclear what it's going to be. And we're not preparing for this. It's just kind of we're letting things happen, and we're like, flopping around in the wind as it blows past us. We need to, I think, have a more proactive approach. And also the technologists. It's not great that we're throwing all this technology together. I know it's miraculous, but we're just throwing it together. We're not figuring out how to make it usable in a really coherent way.
Yeah. I wonder, though, if this isn't possibly an opportunity for the tail to wag the dog here, because, as you point out, we have a pretty well put in place trauma system, and it's one thing if you're moving from, let me state this, if you're moving from one clinic to another, all right, so there can be some overhead and take some time to get everything transferred over, but if you're actually delivering a patient in an emergency ambulance to a clinic, there's a pretty high urgency to solve that problem. So maybe that's the tale here that says, let's tackle that problem, figure out how to get the necessary, the picture I have in my head is this clipboard on the back of the gurney as you're going from ambulance to airplane and it falls off and gets lost. I'm like, this is news I didn't really want to hear today, but so that seems to me to be a pretty recognizable problem that can get public awareness, right? Because we all know people or have been, in the back of an ambulance. So this is one that could get focus and attention, solve that problem, and let that help to wag the rest of the dog, if you would. So you mentioned the iPhone, which little flag went up in my head, and that is the security aspects of this, right? And I don't know how much you looked into the security pieces, but clearly as you're collecting, what's been going on with this patient information, and passing it around through the ether, security becomes a very important piece of this. And we'll talk in a bit about mobile apps and iPhones and all that sort of stuff. But what did you do specifically on the security front, and how much of that is still a work in progress? I imagine.
Right. None of the stuff I said would have made sense without HIPAA security. Right? So we actually I had 2 years of classes just focused on Boyd architectures, how to bring your own device security architectures. So we had to work hard. We're using Corpios security, if you're familiar with that, to ensure every node is a trusted node. The channels that this stuff travel at is encrypted. That's not a problem. Keyword management. I'm working on an NLP project right now, so key management is a big issue, but eventually we solve that. So there are a lot of stuff in security that we had to build ourselves. I wish if your device could work with a tablet right now, that could simplify a lot of our security stuff because it has a neat solution. What you have on that device is what we had to build as programming. That's energy that goes away from the functionality and the stuff we need to put at the application itself. Security for these platforms is really generic for everybody. But one problem we faced with the tablet is when it's because when the vehicle is moving in noisy areas, there's no signal. So, and we really didn't want to save anything on the tablet. We didn't want to back up anything on the tablet, and we felt we can get free with all kinds of problems. But at some point, the connection gets lost, and we had to back things up until the connection comes back. And that required we encrypt intermediate data until the connection comes back. That added another level of security. Now, reliability, I want it to be data immediate, I want it to be reliable, and I want it to be secure. Tell that to your engineers, on a small salary. But we had to deal with these problems big time, but ensuring the trust of the node, having a trusted network of connected is the biggest issue we had to deal with. And that, this stuff, we have the long list of HIPAA stuff, otherwise Boston children would not have talked to us about it. So we became actually their teachers on HIPAA security, so that helped us some. Okay. But you cannot design this stuff without having security as a starting point. HIPAA security should be a starting point to your design. If you don't have that to begin with, don't start that app. It's just not going to go anywhere. You have enough, right now, technology-wise, we're using the most sophisticated you can do, but we still face the issue of the business model. How these kinds of technology are going to make money, even when safety is clearly a value here.
Yeah,
right? I mean, this is, tell me how to answer that question, and I'll listen.
Okay. I thought maybe I'd do a little bit of a change of gears here, just talk a little bit about more of the health provider to patient opportunities for devices and apps. So who here either has or maybe knows someone with a smartwatch or the tracking watch that's monitoring your health? You guys have those, or counting your 2,000 steps a day or whatever every day? So I think this obviously is a huge opportunity to collect a huge amount of data, and can be, today it's mainly use your own app and see what you've done for the day, right? That information, as far as I know, is not yet being reported anyplace back in the medical world, but clearly it can be. And if the ability for us to use wearables that are tracking our health on a minute-by-minute basis, that information can be fed back into the medical world. So when you call up and have a problem, or you're found lying on the street someplace, all that information is available to help diagnose the situation. I wonder what you guys could comment on in that space, kind of where we are today and where you see it could go and what some of the challenges are.
Yeah, so I'll bring back up the dichotomy, not dichotomy necessarily, but the difference between health and health care, right? So what's important to a person's health, quite frankly, is not that important for me, for the health care, right? It really doesn't matter how many steps you took to me, right? If you're telling me that you're exercising, 30 minutes 3 times a week, I'm good. I don't need to know the number of steps, seriously. So the question is, how do you translate the information that is collected into either not important for me, go away, or important for me but in a whole different form that's actually useful from a health care perspective, right? So, and right now, most of the information that's being collected, again, it's about health, and I think it's important. I think it's a good thing that patients are engaging in their health in that way. So I'm all for it as an internist, but I just don't need to know about it. And quite frankly, even some of the things that are happening in terms of, if you're checking your blood sugars, you check your, some people are really obsessive about checking their blood sugars. They check it like 6 times a day. I don't need to know every blood sugar, right? So really part of the challenge is when you, as this information comes in, it's not necessarily information overload. There's some aspects of that. It's really kind of what's really important and what's not important, and so should there be a layer somewhere that is intelligent enough to say, you know what, this is important. I'm going to pull this out of the information I'm collecting from patients directly and plop that into some kind of heuristic or something on my end that allows me to, most importantly, actually predict. That's actually the most important aspect of it. It's not just I know what happened over the last 3 months, because that doesn't help me know what to do about you necessarily in the future. But I want something that adds in and allows me to predict what the next steps are going to be. So what I'd like to see is, and this whole panel is like what I'd like to see. So what I'd like to see is adding in patient collected information, however that is. Some people have home units and the watch and all that stuff's wonderful. Add that into the universe of all other data that we're collecting around that patient and groups of patients to inform some predictive analytic approach that is constantly learning, so that it's not stagnant, it's not just an algorithm, but it forms that so that now I actually can manage a patient or a population of patients in a way that's forward-thinking and forward-looking, and so that when that information comes into me, I can say, it looks like they're trending towards badness, whether that's an ED visit or, being found in the street. So when you mention that, being found in the street, I would hope that the information got to me so that they never were found in the middle of the street, okay? Unless a bus hit them or something, which I can't necessarily predict. So, that's what I'd want, right? To be able to prevent that part. So to me, ultimately, that's where that information, that's how it should be helpful for me.
What you're asking, I think what you're asking for is right, but what I think that means from the technology side, this is what I'd like to see, is this is a business opportunity for people to do these kinds of analytics. But to make it a real opportunity, we need some way to know what the data is going to look like. We need, this is the issue of standardization, raising its ugly head. If it happens, you can have people competing for your business to get you the information you want. When all the stuff is coming in hodgepodge in different kinds of ways, you're basically stuck with the vendor that's offering you, that service, and it's not going to be as useful. And I think this is an example where the lack of standards is actually depressing the business opportunity. Because if it was there in the way you're asking for, you would have a lot of people with a lot of analytic skills offering all kinds of business solutions. And given the ubiquity of the stuff that's going to be ubiquitous, there's going to be a ton of stuff around. You can make a lot of money by charging just a little bit, for every piece of analysis.
I'd comment over here.
They want to, especially when we get to the patient monitor data. Right now we're in a world where the fit are trying to get fitter, which from a healthcare perspective is like, ooh, maybe the 0.1% of cost will become 0.99% of cost. I think the real business case for that is aging at home. And there's been a number of studies that have looked at some unique sensors. Like there's a company that has sensors in light bulbs, and they monitor the elderly and whether or not, whether they're walking around the way they normally walk around each day. And it's anomaly detection. So, if you're 93 and you're normally out of bed at between 5 and 5:30 every day, the day you don't get out of bed till 8 o'clock, that's probably the red flag that somebody should already be talking to you to stop from you being found out, because they deteriorate over days. They don't just generally fall over. I'm an internist as well, so most of my patients, when you really get them in the hospital, you're like, so when do you start feeling bad? Christmas. Get it Easter. I mean, it's been months, and then their routines have drastically changed. Now they stopped cooking, and now they're waiting for heart failure because their family started bringing them McDonald's, and we could have detected that there was anomalies in their activity levels or in their heart rates. I think aging at home is actually a really good business case, and we don't need a lot of data for that. I mean, as far as standardizations, how many steps they did, what their heart rate is, some local location, how many rooms did they go to, and the analytics for anomaly detection has been out there for a while. I mean, this isn't new technology. It's just a mashed up use case, but Apple's not really interested in going after that group. They're after getting the fitter.
Right.
I think it's healthcare. We're looking at these mobiles, and we have to say that's where we need it, and do the fight to get the security so that we can get the ambulance to plane to ambulance to hospital type things.
But there is a lot of money in that business model, because that population, if we can keep them at home and take care of them well at home, and I would add like a weight monitoring and things like that, especially for your CHF example. That's where potentially the providers can start to share in Medicare shared savings, right? So if you're able to manage those patients well, there's a lot of potential for savings on the back end from the providers, and so they might be willing to, and we certainly are, invest in those technologies that allow us to manage those patients better, keep them out of our EDs. Quite frankly, even though they're our EDs, I'd rather keep those patients out because I make more money by keeping them out of the ED than I would if they come in. So there's a lot of potential there. Whether or not Apple wants to jump into that business, I think there's still some potential there.
Yeah, and I think there's. I mean, so my grandparents, one just passed away, my other one just had to go to a dementia unit. But if this was an available service a year ago for $25 a month a person, we would have paid out of pocket, just so that we could have had the monitoring, even if it wasn't going back to the doctor. It's 4 states away, and my parents live next door when they're around, but they go places. And I think this is just one case, but I think there's a lot of cases where we can get that private sector, personal, I'm interested in my health piece, or I'm interested in somebody else's health. There's a lot of, I'm interested in somebody else's health, and maybe even if they're in the nursing home, I still want them monitored, since it's just for everybody. Especially
Good. Carol, thoughts on the opportunity to monitor end users, whether they're health nuts or whether they're a aging population, and whether I guess also we're ready for that from a privacy perspective, because there's obviously challenges.
No, I just support your point about there are simpler things than the standardized. Because I think of myself as a use case. I come from a family, with diabetes. My brothers and sisters and mother, but I don't have it. And I'm always wondering when is my turn. And I know there are things I can do to keep me away from it. But I don't know of a device that can help me with that right now, because that's something I am very aware of this, and I know it has amazing implications in terms of health. Mm-hmm. But where is that mechanism where I can say, oh, okay, I need to exercise a little bit more to keep it away, So I would buy something like that tomorrow if it's available.
We talked about these end user devices that are tracking the fit to get fitter, but can devices be created that actually do help the chronically unfit? There's diet suppression techniques that can be pretty obnoxious, I guess. But are there devices that we should be thinking about to look at the broader population and the general problems, smoking cessation, and all that sort of stuff?
I think one of the problems we're talking about is a lot of times you get solutions looking for a problem. Mm-hmm. And I think the way to turn this around is to start figuring out whether, I think this idea about, Medicare shared, the shared savings program, getting a lot of these entrepreneurs to understand where the money is. Mm-hmm. And in theory, the money, especially for Medicare, the money's oriented toward, solving real problems, because if the problems aren't solved, taxpayers pay more. Mm-hmm. So I think that might be, a better way to start addressing this, because there's incredible things. Google is starting to literally develop fabric, real fabric, that's going to be live. Digital, collecting data, doing all kinds of things. Well, I think the issue is what are the kinds of things that could really make a difference in health, and then you let them, start figuring out what they might do there to bring that to market. But otherwise, I think what we get a lot, I see because I talk a lot, is people get crazy ideas. I'm probably one of them. And this sounds great. Well, it sounds great, but you just thought about it. It wasn't because someone said, "Here's a concrete problem we're trying to solve." It's just I had a cool idea. And I think we have too much of that, and we need more of here are the problems we're trying to solve. Here's the value that they would have for society, therefore for you as a business.
I think if I look at it from an engineering perspective, one area that's important to me, and this is not about the money, but just us as IT engineers and our ability to contribute, will be mental health, technology for mental health. From all kinds of aspects, I think there's a lot of expansion and focus on these different areas, but that is, I have a student who developed an app, that allows a person to join certain kinds of social networks to do with depression and the like. That's an area that could benefit from a lot of innovation, and it's one of those most difficult areas with a huge impact on society. This is the unseen, the unknown side of society that could benefit, versus just me getting a bunch of sensors on my body, but things get a little bit more complicated when there's this social dimension to who we are, where technology needs to contribute, but it takes more than a programming exercise to make work.
We know that there's some, to your point about, there's some of these maybe simple solutions that actually are solutions to problems that we actually are trying to find solutions to. So there's data out there that shows that if we actually are monitoring weight for people with their weights daily for CHF, this is why I brought that back up again, right? We know that we can actually change the curve of the way that they end up kind of interacting with the healthcare system, right? So if I can monitor and know that they're up 2 pounds, they're up 3 pounds, they're up 4 pounds, it's time to do something, So we know that there's actually data that says that works. So then the question at this point, so we know that the monitoring works. We know it's a problem because I don't want the CHFer to come in and CHF exacerbation. I want to fix it before that happens, right? So that's a problem. And so the question now becomes, why haven't we rolled that out more broadly? In terms of, again, just home weight monitoring. Now, we do some of that. I've seen it happen, but a lot of ways that we do it is I send a nurse there to take the weight every couple of times a week, right? Really? So so why aren't we there yet? That's where, again, as someone who's thinking kind of from a senior leadership level, and I've only got so many nurses that can travel around seeing my patients, right? That should be an easy, low-hanging fruit solution around, kind of managing CHF patients. So to me, there are enough. To me, this is an implementation science issue more than it is develop more, innovative products. Implement the areas where we already know there's evidence to show that an intervention is effective in a problem that's important. Okay.
This is interesting. One of the ideas I've had, and I don't want to get into all this stuff, but this kind of fits in, which is what we need is some kind of way for having a kind of requirements definition, problem description that's available for people who are entrepreneurs, low cost, but in depth. So if someone wants to know, someone wants to do something entrepreneurial, it would be really cool if, especially in the healthcare space, there was some place to go where people like you who said, you know what, here's something I think can be done, here's what I need. Put all the stuff in, black and white in such a way that somebody can try to meet that need. Because I think a lot what happens is a disconnect. Yeah. You know a lot what you need, but you're not talking to people who implement. It's not your job to talk to people, no matter you find them. But if we made something available so they could find you, then maybe we get things that were more useful for the healthcare.
That's certainly possible. Yeah.
From the implementation side of things, I think we're in a push market. So my grandfather had the scale 10 years ago now, and he stood on it and said, "Are you short of breath? Mm-hmm. Are you feeling okay today?" And used the telephone line to send it off.
You send it over.
We have way better technology than that now, but they work. But what we don't do is have anybody that's really saying, "Hey, if you know you have CHF, you can buy this scale for $20, and you can subscribe to this service for $5 a month. And whether your doctor is doing this or not, we will call you, or we will reach out. We'll let you know that there's a problem. Or I can pay $5 a month for my grandfather, and I can yell at him that he didn't step on his scale, and the service will call me and say, hey, he's up 5 pounds, you should call his doc." We're very much on this health system is pushing this out, this health system is paying for it. We haven't got it all into mobile consumerism on these things, at least not that I've seen. Maybe I'm just in Mississippi and missing it, but but I've been very surprised that there hasn't been a service that says, we know these things work, and if your health system doesn't provide it, you can buy it, and it's this value. Because it's a patient adoption problem.
Do you think there's not enough money in it so that there's not investors? Because normally, if there's profit to be made, people will go there. We could do a healthcare incubator that does exactly what you're talking about.
So there are companies right now that we've talked to, the health system, that have come to us and said, if you give us $25, we will put a scale in the house for 30 days, and we'll monitor their weight for you for 30 days after discharge, and it's worthwhile to you because of the CMS penalty program. But they have no consumer-facing side that says, I have CHF and I want to pay $25 every month to step on the scale and stay out of the hospital. So we have the technologies, just that we're only viewing health systems as
the only customers.
A pass-through, because then you sign $1 million contract and we manage 10,000 patients instead of
one by one, right?
But you might argue that it's more important to the patient to stay out of the hospital than it is for the hospital to keep the patient out. So it seems to me that they're missing a huge market there. I think it's a great point. There's a huge market there, and whether the patient or their caregiver is really invested in that care, I think there's definitely a missed opportunity right now.
Because right now in the payment program, I'm only motivated to keep you out of the hospital 30 days.
Mm-hmm.
I mean, so actually, as a doctor, I'm way more motivated than that. But from a health system perspective, the penalty system is 30 days. Ideally, you would come back every 31 days after discharge.
Yeah,
Because
I get paid again.
That I get no penalty. So if I were truly working in the system, I would get you to be readmitted every 32 to 33 days. And bring you in for 48 hours, get you tuned back up, and get you readmitted. So even our current system doesn't encourage a CHF patient to not get admitted for 5 years.
Yeah. Those are called perverse incentives, by the way. So, yeah, but no, it's true. It's true. Again, unless you're in the Medicare Shared Savings Program, in which case, if that Medicare patient is assigned to me, I'm responsible for all of their use, all their healthcare kind of costs for an entire year. So in that case, I don't ever want them to come to the hospital. But it's a slightly different model, and that Medicare ACO model is not as prevalent as the readmission penalties are across the board. So that's much more prevalent.
I'd like to stop and ask if there's a venture capitalist in the room.
I got a quarter.
We'll put a pile, collect some money at the door on the way out. So this is good discussion. You mentioned mental health, and I think mental health is clearly an issue where we'd love to monitor everybody to find out who's the next one that's gonna snap and go crazy on us. But then obviously you've got privacy concerns. And I just was thinking. I know Carnegie Mellon and a number of folks are doing research to detect what's going on in someone's head by how they're typing on their keyboard, right? So there's ways that you can monitor behavior and make judgments about someone's mental state. And I wonder if there are, and this could get to a big brother kind of question, but devices that could be developed that would help to, and presumably use this on suspect individuals and not the world at large, but ways to detect if people are crossing over certain boundaries and alert them, possibly alert medical staff.
I mean, it seems to me that one of the options, it was a great to bring up mental health. It's something that's near and dear to me. Our hospital has our inpatient psychiatric unit. It seems to me that one of the early, again, I'm thinking much more kind of in the low-hanging fruit area than like trying to prevent the next kind of crazy person going into churches and shooting people. But some of the low-hanging fruit might be just kind of, again, chronic disease management, just like CHF, but in the mental health side, right? So I've already established a relationship with a patient. They have depression or whatever the diagnosis might be, right? And can there simply be an opportunity for them to, on a regular basis, just kind of give me an update on whether or not my treatment is working effectively, right? But on a regular basis. And so it might even be a couple of questions that just pop up on there, just like a text where they pop up and you just hit yes or no, boom, done. And now I get the information to know whether or not my treatment is actually being effective. Now, we do that now, but essentially I have like a nurse or someone call and say, how are things going? How are you feeling? You're not feeling, if you're feeling bad, come to the ER and all that stuff. That happens. But is there a way that we can do that in a way that's actually, one, it's less resource intensive for me, but potentially even more effective? By having the patient kind of interact with a system that allows me to kind of understand how they're doing. So I think, again, chronic disease management in schizophrenia or kind of other psychoses or in depression, those to me, it seems like you've got a large population, huge population there. And then, might a health system be willing to pay for that? Potentially. Might a patient be willing to pay for that? Might they be willing to think, oh wow, if these criteria come together, and that means that I'm not quite where I should be. I might not have recognized it, but because I've answered these questions over this time period, right? Maybe I should interact with my provider now because I have the information now, and it's and I'm in charge of my own health. So
the thing that would I think help this out. This is really an analysis question, which is, entrepreneurs want to know what it's worth. So how much money are we spending, for example, Medicare spending on these particular mental health issues?
Oh my goodness, it's in the billions.
Right, of course, but I'm saying publish that and saying, here's if you can reduce it by like 2%, here's that's how much money is going to be saved. So that's a big chunk that you could be going to. I mean, I think those are the kinds of things that we have the information. All we have to do is just do some analysis, not a whole lot of it, make it available, and I bet you that would really get a lot of people thinking about what they can do to make some money that would be.
That's a simple analysis. Simply, is depression a primary or secondary diagnosis, done, because you know how much you're paying for those patients. It's easy.
Thoughts?
So I'm going to put this out here so I don't forget it, but as we're talking, I have an 8-year-old that's got pediatric depression. So not like today, but if she becomes a tween or an adolescent and continues to have depression, I would pay through the nose for a service that I could sign up her Twitter account, her Instagram account, her Facebook account, her email account, so that I didn't have to invade her privacy, but would semantically score it and go, oh, holy cow, she mentioned suicidal ideations twice. You need to do something, or these are getting bleak and dark, so that she could continue to be a teen and a tween without me looking over her account, because if I'm looking at her account, then she's not going to express them. Then she's going to have another account that I don't know about that she's having. But as we're sitting here, I'm like, there are mobile things that could make a lot of difference in the mental health field that are, patients or parents or children.
So actually, I'm doing some work on language, natural language processing in criminal activities. But now it came to my mind, there's a different kind of an application to something that's close to my heart, which is applying natural language processing to issues of mental health.
That's interesting.
That should be even more so. It could be the keyword stroke, but language, I think, will be even more powerful in sensing.
I would think so. And, in there we can strip out the privacy concerns, because if I
sign up for the service, right?
Handles and say, I want you to monitor me, because if I start, talking about rainbows and unicorns, I want to know that I'm becoming delusional again, or things are, are sounding dark, or I'm talking about not getting out of bed or whatever. All the privacy stuff goes away because I signed up.
Or you stop talking.
Just
That's what you picked up on that. Question here or comment?
I feel like in mental health in particular, a lot of the high cost comes from folks who don't have access to good mental health. So not only do you need to monitor when someone like that is going down, you need to give them, cheap from a healthcare perspective, access to healthcare. So I think when you have that intervention, whether you detect it, or then you intervene by giving them a resource. I think, particularly in mental health, that's hard for most health systems.
Right.
It's true, but a lot of the times, I don't know about a lot of the times, I don't have the data, so I don't want to say I don't have the data. There are plenty of opportunities for the health system to interact better with those folks, because often it's you end up seeing them because they have some other physical issue that we're actually managing, right? So there's a percentage that's isolated, mental health issue, but there's plenty where it's comorbidity between the mental health and the physical, right? So we actually have to be better at, we as providers, identifying that and then intervening on both. We're really good at the physical. We can fix that up, right? We'll diurese you out, fix your CHF. And then, you're depressed? Okay, you should go see your primary care provider about that, right? So we actually should be a little bit better at that. And might something like some kind of mobile approach to that allow us to have more ongoing access? Because often, if someone comes in and they say they're depressed, for me, it's not an acute issue. The fact that the fact that they are coming in with chest pain, that's an acute issue. I got to fix that now. Depression, I can kind of manage that maybe. But partly the reason why they have chest pain is because they're depressed. And that's one of the underlying issues that we haven't figured out. So I ended up doing a bunch of testing on them, spending a lot of money to find out that they have clean coronaries, and they're really just depressed, right? So it would actually be helpful from a healthcare provision perspective if we were better at what you just mentioned.
You see, because even when you have a good therapist, say, that communication, just leveraging that these kids are, for example, if they're kids, they have an iPhone, they're close to their iPhone, and now you're comfortable, they're talking to their therapist on a regular basis, even assuming the right quality of care. That continuous communication is going to be necessary and a good interaction model will be very powerful in supporting that.
Good. So I do see that we are essentially out of time. I tell you, I'm going back tomorrow night to Silicon Valley, and I'm going to kick off some of these ideas. Sounds like a pretty stimulating thought process here. I think what I'm taking away from this is that, we've really scratched the surface here, and it's not. So the iWatch is great, 1/10 of 1% or whatever, but there are real problems out there that can be solved. Our solutions can help to bring solutions to the front to take care of some problems. And there is money being spent that could be spent smarter, and money saved by thinking the fiscal side of this, thinking the problem side of it, and thinking the technology side, and bringing those three together and coming up with a real solution. So I kind of feel like we've uncovered some good ideas, and appreciate both you guys for helping to drive that. And thank you, audience. So.